Wait a minute. We'll do a mini stop. Because I didn't record it. It's about the exam. I mean, and there's a handful, at least one person in this room didn't, I'll have to get that posted. Because you probably speak with other students who are in the same programs. You are here on the campus because you have lab and different things with them. There were, not everybody. We had in every class of the 4 that I do, and that's all. We had some good schools. By and large, the word I was coming to, disaster. And so it's the reason I closed the door because the nicest man in our department is teaching next door, Dr. Robbins, and because of, and it's not a reflection, you were put in a very awkward position because of this lab situation. I can't hold people. Okay, here's my usual cliche. When something doesn't go your way, you know where the first place you're supposed to look? Mirror. And it's not an indictment. Because of circumstances that were unforeseen and unchangeable, your lab had to be done in this 8-week window. It's too intense. You all know that, to be done in 8 weeks. And it makes studying for this, which is 3 credits, that's 1, much more difficult. So we'll start with that. 2, I should have done, I tried to adapt for that, as I had told you. Tried very hard to pick a week where you didn't have this intense lab stuff. I think that was naive for me to think that just because it was a week, it was still going to be intense. And you would have had the time to do adequate preparation. But I still had to get material, and at the very least, I needed to have, at least I can acquaint you with the way I make up tests and how tests are presented to you and kind of what you have to know. I should have done better. So this is the mirror part for me, about making sure the amount of stuff that you didn't have to study that wasn't going to be on the test, because then you don't, if you know it's not on there, you can just let it go. If I tell you just, here, I'm telling you this for information, background, go from here. That's not the stuff you need to be studying. That would have helped you a little bit more. That's on me. The studying part's on you too. I mean, here's the part that's I record these things for posterity. I mean, the only one of my recordings that people listen to at all were the review recordings. The recordings of the individual lectures, people you didn't listen to. Not you in particular. It doesn't tell me who the person is. When you have a YouTube channel, it tells you the number of views. That's all. I don't monetize it. If only I knew that. But you understand? So that's on your part. Given that once that lab is over at the end of next week, it is time to focus on the credit part of the program. I will focus on it as well. This is all I do is I do the lecture part. So to that end, normally, and you may have heard this already, typically the exams are weighted equally times 4. Me starting off, it would be very, very difficult to overcome as bad a grade as some of the students had. And I speak in generalities, not to anyone in particular, and because by and large you guys are here, and that counts to me for something. At least to me, I feel that's important too. So I can't equally weight them, and so my original proposal was to do make that 10% of the grade and then 3 at 30% of the grade. And in other words, I don't like to discount a performance because most of you guys are in a healthcare field. That's like saying, oh, I made a mistake. It doesn't matter. There's an emphasis on getting things right the first time. In a clinical setting, med errors, treatment errors, failure to recognize something that you should recognize can have dire consequences. We all make mistakes. You're dealing with people. I mean, trust me, I've been on the business end of a lawsuit, the wrong end of it. It ain't fun. I mean, that's the monetary end of it, with or without insurance. It's not the headache that you go through, the agony that because you may have done something incorrectly, or they're perceiving that you have done something incorrectly or improperly or without exercising due care, caused them some kind of harm. enough that they would want to look for financial remuneration. It's not an easy process. I've lived it, so I'm trying to help you not have to live it. That's a little bit of the philosophical saga. Short answer is I said to my wife, this is what I was planning to do. To nursing. She goes, Lou, it doesn't make any sense. Why don't you just drop the lowest grade? That's what we're going to do. You got 3 more tests to take. If you did okay, I would never penalize somebody. That's what I told the other groups. I said, if you did well, I would never drop that grade or minimize that grade. I would only, if I had an alternative plan, I would only invoke an alternative plan if it was to help you. This would be true about this as well. But I mean, we've got 3 more exams. We'll focus on them. Whichever is the worst one, it doesn't necessarily have to be this one. Because that would be 33, 33, and 30. So we can ignore the 10%. And I'll undoubtedly formalize it because I understand there's a syllabus that was involved, and I'll come up with some way to phrase it that's the appropriate way. Because this is an extraordinary circumstance here, and that's probably the way to phrase it. Okay, and if you're uncomfortable with anything I've got, feel free. Please let me know. You don't have to do it publicly if you don't feel like it. I can take the hit. I've had students say, oh, you forgot to send me the study guide, you forgot this, blah, 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 blah. It's okay. My ego doesn't get in the way. To pass that stage. That's why I sent the next study guide early on. Today we're going to probably do the vast majority of the bones chapter. Other than that introduction I sent to you, that's where we stand. So everybody got it? That's 6 solid minutes of telling you what's up. We do not want this to happen again. Please. I'll try to do better. You're on. I'll be. Isn't that how they do it? Maybe not. My pop culture references are from 1970. It doesn't count. You didn't have to agree so readily. I'll stick one of my grandchildren on. Okay. Oh yeah, I was just wondering what they're saying here. All right. So let me summarize. This is what so the other documents are there. Of note, I did discover, this is from my advanced class, they said, you have outlines for a lot of these chapters. I have one for bones. So I just put that on your blackboard. It's under Unit 2. Plus the chapter I used for the last, that sort of supplementary lecture, because you needed it. It kind of keeps us on track. That was the finishing piece for the week. And so all of that is on. So all of this is here. No question about it. So you can look at that. That'll help with your studies, I'm sure. I would plan on the 29th. I'll tell you why. Yeah, not saying that you have to consider this, but October 31st, this year is in this semester happens to be, and it's typically the end of October. We call it the drop dead date. If you have to withdraw from a class, it's always better to take a withdrawal than to take a really bad one. People will tell you differently. That is not true. You can always explain a withdrawal. All you have to say is it's a personal family matter, and that ends the discussion. Nobody else can ask you anything else. That's the way it works. If you have like a personal family matter every semester, now we have an issue. But if you wanted to go out of sequence and take something, you can do that. Most likely, if you took it again in the fall of next year, you're stuck with it. And it's not, and I don't say that facetiously. Understand that I am teaching styles and learning styles don't always meet. They just don't. Typically, most times it's about 90-10, 95-5. 90%, 95% of the students this works great. Some just don't get it the way I present it. So I'll get a result here. Something about old dogs and new tricks. See, I saw you were look up. So on that, so here you see the bones chapter outline. There it is. Here's the PowerPoint I was using. So let me get back, make sure I'm recording. Now I can start. I was recording anyway. This is all for posterity. Heavens. Okay, so this is where I started with the other groups. I'm using that, and this is the one I messaged to you because again, the Marie, these PowerPoints are just too bulky, by and large, it's too large of a file for whatever reason. Okay, and so this is all introductory stuff. I'm sure you had all this. I don't care about this. Not going to ask you questions about that. The different kinds of cartilage that could be on. You have to know the 3 different types. In bone, it's all hyaline. But hyaline, elastic, only 2 areas: your ears, your epiglottis. Fibrocartilage, you probably learned about that. If not, I understand he didn't do joints, so I'll end up doing joints here, and that's like the knee cartilage, okay, the menisci, the intervertebral discs. Did you cover that? The bone, the intervertebral discs, symphysis pubis, those are fibrocartilage that are there. Okay, that's the cartilages. Our focus right for now is hyaline cartilage for sure. I'll address it otherwise. We're going to talk today at some juncture, probably midway, about appositional versus interstitial growth. Appositional is, and it's the same for bone or for cartilage, it's about shape, it's about width. It's when the cartilage takes on the appearance of what's going to be what's going to become in the shape of the bone, where we're going to have what eventually becomes the head here, or the base here, or the condyle here. Interstitial is elongation, and we use the same terms for, again, interstitial growth for elongation. So, and even though I would dare say, typically students by the time they reach college are pretty much done growing. Sometimes boys are an exception, girls rarely. Your interstitial bone growth is done, and you're going to see that happens when something called the growth plate or the epiphyseal plates close. Okay, and again, and this is the idea. I mean, this is just a point I would have emphasized. I don't think that's a test question. I'll look, but there's a difference. Cartilage is good because it's got some degree of flexibility. As we get older, we lose it. That's why people who are elderly, they can't expand their chest as well. You have the costal cartilages between the ribs and the sternum. You don't get that little give from those much you should as you get older. And this is all the general things. This is self-explanatory what bone does. And we'll look at all those things. I don't have to give you a whole lot. Today, we're going to be talking a lot about the mineral and growth factor, particularly the mineral structure. Understanding the role it plays and what controls the minerals, the different hormones. And this will be a little introduction to endocrine. What controls hormones? Endocrine are hormones that go through the bloodstream directly into it. More about that. That's AP2. Hematopoiesis is part of it because all of your blood cells, white, red blood cells, and platelets, which are effectively cellular fragments that have the clotting factors, all begin and some effectively mature in the bone marrow itself. It's really part of the blood vascular system, circulatory system, which is AP2, but we at least introduce it. And it all has to do with the magnificent amount of available space, the little nooks and crannies that are there within what's called the medullary area of the bone, and all of that wonderful spongy bone that has all of this potential space available. It's kind of draped with red bone marrow. It's not like the bone is for fat storage. I always thought this was somewhat ludicrous. Oh, heavens, I gained a few pounds. My bones must be having extra fat. No. Most of your bones, because you learned about the shapes in lab, I'm sure, other than flat bones, and really 2 areas in long bones, which are the head and neck area of both the femur, of both femurs and of both humeruses or humerus. Okay, that's the only place where you retain red bone marrow as an adult. It converts to yellow bone marrow. If you're sick and anemic, which means you don't have enough red blood cells or enough of any blood cells, under stressors like that, it can convert and it can start to transition back to red if necessary. It's not like Oh, the fat goes in different areas, abdominally, hips, stuff like that, not in your bones. Osteocalcin plays a role with this. I really don't want to get into that. I'll let whoever's doing endocrine take care of it. And I'm sure you did this axial and appendicular. It's not our thing. You always see the same drawings. You can see in blue hyaline cartilage. Here, the ends of the bones which form joints, hyaline cartilage. Okay. Again, like I was telling you, respiratory, which means here you can see the cartilage there. It's called costal cartilage, bringing the ribs and the sterna together. All these things you'll learn about in respiratory. Basically your Adam's apple, which is called the tracheal cartilage, the trachea, the laryngeal cartilage, pardon me, the thyroid cartilage, the rings, etc., etc., etc. And you did all the shapes. Our focus is long bones. That really tells you how bones work, what makes them unique, where they store calcium, how we go about obtaining it when we need it, and kind of how it indirectly sort of reversing it, how it gets put back in. Flat bones, right? We're not going to look at the shapes of the bones. I mean, I will double check on this exam to make sure that what I'm telling you now is concrete, unless I have something specific to tell you that might have been included that I had forgotten or I told you it was not, and I decided to include it. Which brings us to where I started with all the other groups I'm running. You gotta get through that. We're looked to understand what bone is, how it works physiologically. We look at it under the microscopic and chemical level. It really tells you more than anything else. Bone has a lot of other stuff in it, okay? And the fact that it's nerves, okay, all parts of living tissue have some nerve supply. The cartilage is what's left for the most part, at the very ends of the bone where it moves. It has connective tissue, sure. The sheath that's around it is about connective tissue. That's something we're going to look at very, very shortly. Muscle cells, only the fact that they attach, lining and blood vessel cells, okay. So they're part of it, but they're really not the important part. So the two distinctions in bone. Compact bone is also known as cortical bone. If you think of bone as a cylinder, if it would be the plastic of this, soft drink bottle, okay, the hollow area is where the blood forming would be. The plastic that gives us its shape, so to speak, is compact bone. So if I could do the kind of squeeze it, do that type of stuff, you would have more of that compact bone. That's what gives it a lot of that strength that's so important. And you're going to see going forward that there are areas where, depending on whether you're weight bearing on it, what the forces are, the kind of occupation you have, whether you're right-handed or left-handed, all of those things might make one side have a thicker amount. So imagine, again, it's like a cylinder. The thicker you make the walls, effectively the stronger it is. It's a two-edged sword, as you'll find out, but it makes it stronger. And the spongy, also known as cancellous bone. Okay, I use the terms interchangeably. Again, you have the luxury on exams coming up and asking me, this says cancellous. What does that mean? I just look at it, I say spongy. And that's pieces of bone that are not in a very orderly fashion. They're basically, honeycomb's the best word for it. These little flat, needle-like parts of bone, what they afford you is a tremendous amount of surface area. And that surface area, at least in the early days, is used for blood formation in all of these bones. And they play a really important role in sort of supporting the strength of the bone as sort of a base underneath it, as you'll see. This is what it looks like. So the classic, look at it. You have a head of the femur. So here you have the start of the femoral shaft, cancellous bone in the head, the neck. Even this is all part of the bone you're going to come to know now. It's called the epiphysis. There's two, one on the top and a bottom, so to speak. Superior and inferior, proximal and distal, doesn't matter. An epiphysis is the end of a bone. Epiphyses is the plural, is both ends. The shaft is called the diaphysis. When you get into this shaft, okay, you see the compact bone. From the projection they're using, the technique, very, very solid. It's almost uniform bone with a lot of dense calcium. Here, everything is that honeycomb pattern. Okay, the implication of the amount of space that's available is important. Doesn't mean it's not strong. It's strong in a different way. There's actually a lot more give, if you want to think of it that way, in this. So they're short and irregular pieces, short, irregular, and flat bones, rather, basically have an abundance of that cancellous or spongy bone, and on the exterior, a comparatively thin layer of that compact bone. It's like a sandwich. You have cortical bone on the outside, or compact bone, spongy or cancellous bone on the inside. Most of them form the short and irregular ones form out of a cartilage model, because a lot of times they're involved in joints that move. The flat ones are like the bones of your skull and your clavicles. They're oddballs. As you're going to see, we call those intramembranous bones. And it's unclear why a fibrous membrane in a developing head of, probably at that point, it might even still be an embryo on its way to becoming a fetus. Very, very early. First trimester, magically, all of a sudden, bone starts to form it. We really don't understand why that occurs. It occurs. It's just whatever chemical signals, whatever growth signals are not clearly understood, and it forms magically. All of a sudden, now you have starting to become a solid encasement for the developing brain. So compact bone sandwiched between connective tissue membranes, and on the outside, you have this wonderful tissue in all bones called periosteum. It's a sheath. It's a wrapper. So if I took, I'm not talking about a thin, delicate membrane. I'm talking about a thick wrap made out of the same tissue that your deep dermis is made out of, that we make hide and we make leather out of. Around this, it's extraordinarily strong, helps it hold its shape. You have one called perichondrion around cartilage. When the bone gets invaded by a blood vessel, effectively, this is what happens. This is how we get bone from cartilage. Cartilage is not only destroyed by blood, it enables its conversion from cartilage to bone. Cartilage that's been exposed to blood deteriorates. If you have an injury, and it involves a sports injury, a twisted ankle, and it involves bleeding into the joint, rupture to an ACL or a PCL, you get blood into the joint, which is one of the diagnostic criteria for that. That blood on that cartilage that's in that joint is going to cause it to deteriorate. How much it is, how long it's there, how severe the injury was, will determine whether or not it develops into a full-blown arthritic problem, or whether it's something that's just there. That's what we don't understand. Even if you had an operation in there, most likely there's going to be some bleeding that goes in there. So, the more times you invade something, the more times you're going to develop scar tissue and scar cartilage and stuff like that. That's a whole other lecture, but there's a lot to this. When we do the joint presentation, I have a lot of information to share with you about that, and I think you'll find it interesting, I hope. So, that the periosteum is around, and it sheaths, and it nourishes that bone. When you break a bone, that periosteum is disrupted. That's where the pain comes from. Bone has nerves, has very few sensory nerves in it. On the exterior, that's what hurts. When you tear it, that's what hurts. When it gets lifted up by swelling, that's what hurts. You begin to move around with it, if it's not ready, that's what hurts. The interior of bone does not. I have operated on a diabetic with peripheral neuropathy and removed bone from his leg without the benefit of anesthesia. Taking out chunks of bone or a big hole without nipping bone away, chopping it with a pair we call bone rongeurs, or basically it's like glorified nail clippers that are designed for bone. That's so simple. Just go with it. And I've taken it out. No anesthesia. Thank you very much. So all of that's part of it. So you'll begin to see that this is what's meant by one of those flat bones. This is probably parietal bone. You can see that's the trabecular pattern. Trabeculi are the pattern of these plates, or basically spikes or spicules of bone. And you can see all that comes in. That's normal, healthy bone. Down the road, we start talking about osteoporosis. A really important part at the end of this, you will see what that looks like when it's been invaded by osteoporosis, when it's been destroyed by osteoporosis, vividly. And so here's a sandwich: cortical on the outside, cortical on the inside. It's called diploe, fancy name Diploe, with an umlaut over that from the German. Didn't take German, just guessing. So this is where we're coming to. To understand how bone is structurally sound, how it works, what's important about it, right here. You have a shaft called the diaphysis. The ends are called epiphyses. Epiphysis would be the singular, and membranes, particularly that outside one. And rather than me drawing the board, we'll get there. The diaphysis, tubular shaft. Like I said, if I had a tube rather than a plastic bottle, look like that. Compact bone, a little bit of spongy, then this medullary cavity. In adults, it flips to yellow or fat away from red, blood formation. The ends, epiphyses, a little bit of compact externally, spongy internally. What's left of that hyaline cartilage frame, that hyaline cartilage model that it replaces, are the ends. It's beautiful, it's white, it's glistening, it's perfect, and it's in those joints. So your joints move because you have these wonderfully coated areas that allow motion. Like a table, like a top on this platform, a top on your desk, it's smooth, and it allows it to move. It's got lubricating fluid in it called joint fluid. We'll look at that when we look at joints. All that is a fluid that's basically water with a little bit of protein that makes it increases its viscosity. So it's a little bit just like oil you would use. Not much thinner than, say, motor oil usually. And then, okay, I have an issue. This alleged epiphyseal. So the growing bone pattern. You have the shaft, and when it's growing, you have a plate here and a plate here called a growth plate or epiphyseal plate. They would have you believe, someone who either wrote this or read this someplace in a book, that when these close, when you reach bone adulthood, where you're not going to grow anymore, vertically, so to speak, or elongate any of the bones, that there's some kind of a line that's there. I operated on bones for 25 years. Be an old wives' tale, could be a young wives' tale. I don't know where they came up with it. I mean, board certified in orthopedics and in bone surgery. I never had to ask a question about an epiphyseal line. So it's below. You thought I was going to say something else, but I'm not. Yeah, I know. Here you are. This is what it looks like. Okay, this would be a mature bone. This alleged epiphyseal line does not exist. It doesn't exist. Maybe thereby. But here, you can see it very well. Cartilage at the ends. This is a humerus. The shape has to do with the other bones. Again, bone is formed by the forces that are on it. Okay. The famous rule is called Wolff's Law. If someone is in a terrible accident and becomes paralyzed and has to be in a wheelchair, their bones are going to adapt to that position. If someone has a stroke, and all of a sudden they can barely move this, it's going to adapt to this position. If they have arthritis, rheumatoid arthritis, and their hand gets gnarled like that, the bones have changed position. A lot of the work I did surgically was in arthritic cases like that, where we had to cut the bone crank it in one direction or another to straighten out the finger, the toe. So that's this idea of adaptation. So it's not like they don't all come in nice and round, so to speak, kind of like that is. It doesn't work that way necessarily. Depends on what it's up against. The big deal here is it starts to give you an idea of the thickness of the periosteum. There's lining called endosteum here inside the marrow cavity. What role it plays, I personally think very little in healing of fractures, certainly some. Okay, not nearly as much as the periosteum, which you're going to see a better view of. This is the main artery going in. It's got a famous name. It's called the nutrient artery. You'll see that. In surgery, what surgeons learn is, particularly when you work on bones, where it is so you can avoid it, because you don't want to sever the circulation to the bone. So this would be like where the cartilage is. You'd have some of this is compact bone. We're going to study this. Very interesting. I bet you saw the micrograph of it in lab when you're looking at tissues called cortical bone. It looks like little tree trunks with the rings. Maybe you remember it. We'll get into that. And then we're going to look at the blood supply. That's the beauty of bone. It has unbelievably great blood supply. You have blood going up and down, all of these areas, and blood going at right angles to it toward the interior, all filled with blood. That's why fractures, as long as the bones are close together and the blood supply is intact and you keep it from moving around, guess what? Going to heal. Unless there's something underlying, there's a problem where it's just there's some unusual fracture, or there's a problem, the person has to know that it's a health-related problem some other time. That's there. This is the big player to me. Much more the periosteum. Again, double layered membrane, which means on the outside, and this mirrors a lot of tissue. It's the same material that a capsule is made of. The capsule that's around your kidney, holding it in place. The capsule that's around your joints. We'll take a look at when we look at joints. You have a very, very thick layer on the outside, and then on the inside, you have layers of cells. You may be starting with something like simple squamous cells or something similar to that, maybe some other cellular structures, strong on the outside, delicate on the inside. And yes, all through that, nerves, blood vessels, etc. Very, very sensitive. So again, it's like it's being held together like I use the word corset, but that makes sense. Okay. The next thing I'm talking about Marie Antoinette. It's like Wednesday Addams. See her Marie Antoinette doll, no head. I think on Prime you can watch, if you have Amazon Prime too, you can watch old episodes of the Addams Family from 1960. It's terrible. Moving on. So what those cells are part of what they call the osteogenic layer. Effectively, those are bone stem cells. They're very similar. Understand that bone, cartilage, fibrous tissue all have the same stem. They're called mesenchymal stem cells. They're what connective tissues are made out of. So you spent a lot of time, I'm sure, looking at connective tissue, all the different types, loose irregular, dense irregular, blah, 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 that type of stuff. Effectively, those cells can go from being fibrocytes to chondrocytes to osteocytes, or fibroblasts to chondroblasts to osteoblasts, with a variety of chemical and other signals. They can go in one direction or the other. When bone is broken, you'll see when we get to the healing of bone, and we probably will get to that today, maybe, that the fibroblast, okay, that the first thing that fills it is not bone. Blood comes in and fills it, and then what we see a fibrocartilage callus. Fibrous tissue and cartilaginous tissue start, and eventually they change over to bone as that fracture begins to heal. It tells you all you need to know. They're the same cells. They keep flip-flopping from one mode to another. Oh, okay, I'm going to do bone now. Oh, I'm going back to, we need more cartilage. And so, and it's all of that. The nerves, the blood vessels, they're all in there, all through this. In surgery, we endeavor to, I would do everything possible to keep this intact. What really hurts when it was shredded in like a bad accident. We'll incise it when we do an elective procedure, like to reset a bone or to reposition it, slice it. We have instruments, special instruments that lift it away from the bone carefully. We do the work on the bone directly, and then after we finish with the work, screw it, pins, whatever, we delicately close that material. We bring it back together and sew it back together the way you would, and very similar stitching the way you would sew a garment. And indeed, in surgery, a lot of the seamstress stitches are what we sew with. You didn't know that when they make, you've seen wounds close where they just put a thing called steri strips, if you will. They use something called subcuticular suture. This is an aside. Effectively, it's a blind hem, if you know how to sew. So rather than going through the skin this way, they go side to side. We should do that all the time. And then my favorite part, because I tell the same story and I get to tell it every time, are these perforating fibers. Securing periosteum to underlying bone. It's sewn in, as well as for tendons and ligaments. That's what they look like. I'll go back. Here's those perforating fibers. It's a blow up of an illustration you saw before. How strong are they? How hard is it to put something back in, to put a tendon or a ligament? I'd say around 30 years ago, where the Penguins play now, PPG Paints Arena, if you did not know, it was a hospital. They raised that it was originally called Central Medical Pavilion, and it was bought by St. Francis system, and St. Francis system was later acquired by UPMC. The Children's Hospital is in town. In Lawrenceville was the original, the big St. Francis Hospital. St. Francis bought and became Sanford Central. I operated there for 10 years, 1990 to 2000. And I wrote a case for my private practice. A friend of mine was the orthopedic surgeon here. I had called him in because I knew how challenging it was going to be. So you had the foot. She had, it's called the navicular bone. It's the bone on the side. There was a big tendon called posterior tibial. It kind of creates the arch on the interior foot. She was born with the bone in two pieces. And because it was unstable in two pieces, her foot was flopping on one side. So what we had to do was effectively detach the tendon, take out that extra piece of bone, and put the tendon back in. Well, that should be easy. Good. Now, it was easy for us because we know what we're doing, but effectively to reseat the tendon, taking it out, cutting it away from the bone is one thing. How do we put it back in? We took that, imagine this is the bone. We took a drill, drilled a hole in the bone this way, and inserted, it's polypropylene, it's a high density plastic. We use that because the body doesn't react to it. It's got low bioreactivity. Your immune system kind of leaves the way. We stuck it in there, and it had two pieces, it had a stem and a top. And in the stem, which you twisted the top of the stem, and it caused three little fish hooks to jut out, like grappling hooks, if you know what those are, and pulled back on them to anchor it in the bone. Coming out the head were two laces. Suture material that was fairly thick, and we would lace, and at that point we laced them to the tendon the way you'd lace up a pair of ice skates. That's the same way you would attach a Achilles tendon and pulled out of the calcaneum. Fancy name is called a line tag. I do not know if they still use it because the technology has evolved over years and years. That was the state-of-the-art technology that it took us about 30 to 40 minutes to do the procedure. And I had not done it, he had done it, and I didn't want to, you don't know what you're going to run into. It's nice to have another pair of hands to do. And thankfully it worked out very well. 16-year-old girl. The reason I tell you the anecdote is not to brag about doing a procedure, is to tell you how Mother Nature secures tendons and ligaments to bone and muscle to bone. It's amazing. To understand that, I don't mean to be overly dramatic, okay, but it really, to me, those are the little things that kind of go, wow, that's pretty cool. And the endosteum is relatively delicate. Stuff can get through it. It's got some osteogenic cells. That's the highlight film. Not else a lot going on with that particular area. And you saw this illustration before. I don't think there's anything else there, no. I think it underscores it. We're going to start to look at this ultrastructure in a second. The red bone marrow, again, it's everywhere to start. In adults, heads of the femur and the humerus, okay? But the most active areas are the flat bones, and particularly when we do it, like if you're doing a bone marrow procedure where you have to take some out because it's going to be donated, or put some in because you're doing a transplant, you use the areas easiest to access: sternum and the hips. We learned about the iliac. The hip bone is 3 bones. The iliac crest. You can find that all you got to do is put your hands on your hips, and that's flat bone, and that's easy access. You numb the area, you make a little incision, spread it apart, and you basically take a sterile hole puncher. Punch a little hole, take out the little circle of bone, and suck out the stuff, or push it. No mean to oversimplify it, but effectively that's what happens. Bone marrow is really important because if someone is anemic, that's one of the ways, if you don't see an obvious cause. I mean, unless they've got an obvious blood disorder or something, but you're kind of looking to see, is it leukemia, which is effectively a bone marrow cancer, or is it something else? You always have to do a bone marrow aspiration. You won't have me for AP2. Unfortunately, my health very checkered. I had to undergo a lot of transfusions, none within the last almost 30 years. But I was fortunate to never had it. I was bleeding internally. You did this. This is lab. You won't have to know a trochanter from a tibial tuberosity, from a spine, from a notch, or any of that. You don't have to thank me. It's all on the surface. Okay? I'll talk about your acetabular. You won't have to know it. Your condyles and or epicondyles. You won't have to know. We'll revisit epicondyles soon when we get to joints. So it's important to know about these. Those are facets, not facets. In my world, you have to accent the right syllable. It's a joke. I hate everybody. Okay. Bone. To understand what bone is about, you got to look at the cells. Only 3 of these cells really we understand as bone cells. No one really knows what bone lining cells do, so I'm never going to ask you that. Osteoclasts are not bone cells. They're how bone gets dissolved and remodeled. They are basically a unique cell with multiple white blood cells that are activated, as you'll come to learn today, by something called parathyroid hormone. And what it does is it gobbles up bone to remodel it or to release calcium, because that's the second part of today's presentation, talking about that. The other 3 are significant. The osteoprogenitor, that's the stem cell. That's that bone, that's that cell in the periosteum that basically is going to form the osteoblast. When a cell has the suffix blast, it means it's active in producing ground substance and fibers. Fibers are always collagen in bone, and the ground substance consists mainly of a protein known for its ability to bind calcium. Indeed, they call it calcium binding protein. It's the whole way bone works. Okay, when you have fibers in this ground substance, it's firm to start. It attracts calcium salts, mostly calcium phosphate, maybe some magnesium, maybe some other types of calcium, but mainly calcium phosphate, vast majority. And it pulls that in, and that firms it up so much it takes it from being firm to solid. That's effectively what bone is. Bone would be fairly strong without the calcium. With the calcium, it's unbelievably strong. mean, you could take a piece of steel that's comparable and bend both of them. They would break at the same strength. It's the strongest steel if you're interested. And get this, we are continuously replacing our bones. None of the bones you were born with are still with you. None. And none of the bones that replaced them at first are you still with you. They're gone too. We're continuously, that's the beauty of this particular presentation I told every class today, is to understand there's not a whole lot of stuff that stays with you. That was that whole cell cycle thing. The good news when cells then exit the cell cycle, they don't get cancer. They don't undergo mitosis. The bad news is they become irreplaceable. Your brain, your nerve cells, spinal cord, heart muscle, skeletal muscle, smooth muscle. If they're damaged, they just heal with scar tissue. They no longer function the way. They don't function at all. Understand that. Everything else is continuously being replaced. All the linings inside your hollow organs and blood vessels, in your gastrointestinal tract, in your respiratory tract, they're being replaced all the time. All of your bones, your cells, your red cells, white cells, platelets, they have a limited lifespan. Red cells, 2 to 3 months, 3 to 4 months maybe. Gone. You have to understand that. It's really the beauty of the body, in the sense that as long as we take care of it long enough, if there's a problem, it'll get better over time, even if it was something that's relatively bad. So, and there's a lot of good news and bad news that goes with it. There's, that's the trouble with a lot of safeguards. Sometimes, and you will hear me say this a lot, it's a much better talking point in AP2. Here, the point will be osteoporosis. A lot of people aren't aware they have osteoporosis until a bone gives way, called a compression fracture. All of a sudden, they have unbelievable back pain out of nowhere. Oh boy. That's because it's a false sense of security. Well, I had x-rays done last year. Nobody said anything. It doesn't show up till the bone's about 75% gone. And then the next time you decide to jump off the last step or miss a step, or something like that, jump off the last rung of a ladder, jump into the pool, boom. All of a sudden the bone gives way. So if we think everything's going right until it's usually in a lot of these systems, until it's about 75 to 80% gone, and then all of a sudden it's gone. Well, I didn't know that. And that's why understanding family history for you, understanding patients' history is so important. Understanding what risk factors are, all of those things. That's part of the picture. Just to give you an idea. So those progenitor cells gives way to the blasts, which makes the ground substance and the fibers. When they are done making them, okay, for the time being, and stop being it's not like they stop being active at all, as they don't have to be as active, they stop and they become what's called osteocytes. They can go back and become blasts of chemical signals, or in response to an injury, or any type of something that a stressor that might cause them to do that. They're still the same cell, maybe a different phase. That's the versatility of those cells. Again, bone lining cells we do not understand, and the osteoclasts are really much more of a modified white blood cell or grouping of white blood cells, really specifically for remodeling bone, the main role releasing calcium when it's necessary. The biggest role I think bone has, other than the fact it supports things, okay, and blood formation being set aside, is its ability to bank calcium. It's calcium 99%. All the calcium we have is in our bones. And we're constantly taking it out, putting it back in, taking it out, putting it back in. So osteogenic cells, mitotically active, they stimulate, fine. 2 parts of bone. The organic is called osteoid. You need to know that. Collagen and those calcium binding proteins. The whole idea, maybe you went over this in connective tissue, what makes, and maybe I told you the same thing, the idea that the mixture of fibers and ground substance, when you put fibers in something and it firms up, it gives it strength. I told you about rebar, didn't I? They make, if you're putting in concrete, You build a sidewalk with concrete, they'll put a metal frame and you pour the concrete over it. That's, you see the road, go and look when they do road work, and when are they not doing road work in this state? We just went through West Virginia and Maryland on our way to Virginia, outside of DC. You know immediately when you get to Pennsylvania. It's not like it's not like we're not paying taxes. We're probably paying more. It drives me nuts. So understand that, and once it has that to start with, it's strong. Now you bring in the calcium. Now you have rigidity. Now you have bone. So here, the osteoprogenitor cell, very indistinct, as is the osteoblast. When from this illustration, and this is what it is, it doesn't. The more things, the more organelles and things like that we see give us an identity to cell. What happens is it's generating this stuff, and this is really the sort of the misnomer with cartilage and with bone. It's highlighted, and it's important to remember. That's code for it's a test question. So you should be learning. By this time, you start to learn terms. That's why I record these things, because I tell you what's on them. The lacunae are these little enclosures that we find. It's an optical illusion. It looks like a cavity. To me, it's there because it doesn't, for whatever reason, stain does not attach to it. So on a slide or on a micrograph, you see there's something in there, but you don't see it uniquely. So it makes it appear that the cell is surrounded by empty space. It's really not. The body is not fond of empty spaces. It fills them. Empty spaces are bad. So it fills them for the most part with fluid or some other type of material. So what happens is after they made all this stuff and it starts to attach, effectively attract rather than attach the calcium, what happens is, you see this. So here's it's forming all these, the calcium's be attracted around it. And eventually what it does, it firms up here, and it creates what appears to be these tentacle-like projections. Effectively, even though they're a hallmark of the osteocytes, the cells are all interconnected. It's connective tissue. The cells are connected. They touch each other through these long tendrils and send either chemical or electrical signals to one another, basically saying, hi, hey, we better start making some more bone. This guy's putting on a few pounds. Or, take it easy, finally on a diet. Obviously not talking about me. Not that funny. Dad, I'm looking at you. It's all right. I told you this. My wife says, Lou, you got to get into shape. Pound is a shape. Which is usually attracted by a SWAT. So that's an osteoclast. So if we go backwards and look more at these things, here we go. Bone lining cells, really don't know what they are. Flat cells on bone surfaces, believed to also help. Whenever they have believed, may be possibly associated, that's code for we don't know. No questions. Thank you very much. So the osteocytes, they respond to stimuli. They communicate information to other cells, whether we need to make more, destroy more, convert to osteoblasts, etc. The osteoclasts are really white blood cells. Clusters of very large ones called macrophages. They call it multinucleate. It's a big cell that has multiple cells within it, multiple nuclei, because of multiple cells. It has a lot of surface area. It's called a ruffled border. And they form, and they're all along the bone in something called a resorption bay. The ruffled borders are important. The fact that it's multinucleate is important. The word resorption bay is important. It's important because that's where the calcium gets pulled out of the bone. And they use enzymes, which we'll talk about a little bit, to degrade. This is what they look like. So you can see in the illustration, 7 cells. That's the ruffled border. And they're present all along the exterior of bones. Again, because they're constantly giving up a certain amount of calcium and getting it put back in. So the layers of bone, maybe they're 15 minutes, we'll take a break. So the layers of bone go by a lot of different names. Sometimes the name I learned was Haversian. Some people say Havershan, doesn't matter. The key is the osteon. I don't have it. I wish I had it in this room, but I don't. Imagine what makes your bone so strong is what's on the exterior. It's like this. It has all of these markers. They're like little pillars. Each of those is an osteon. Imagine if we had one trying to hold up a lot, it would be difficult. If we put them all together, it's like braiding I talked about before. The numbers, you get strength from it. They each take up a role. And then we surround them with bone tissue, and we put little bits of bone tissue in the middle to glue them together, making this a unit. That's effectively what the osteon has. And moreover, in these little openings that are within there, blood vessels, as you'll see. So it's filled with blood supply that is still extraordinarily strong. That's the osteon. That's the real structural unit. And when we talk about what it does, it's the functional unit as well of compact bone. The canals typically are, if it's a canal, it's carrying blood vessels, obviously some nerves go along with it. You're going to see the central canal goes up and down the long axis of the bone. Depends on the anatomical position, which way, whether it's horizontal or vertical. That doesn't matter. We just say long axis, the long way. The other canals you're going to see are called Volkmann's canals, capital Volkmann''S. I pointed to it before, they have blood vessels that go tangentially. It means at right angles from the outside to the center. It's like we're all standing around a circle on the outside and we're all pointing toward the center of the circle. That's tangentially. So it's at right angles to the long axis of the bone. The canaliculi, those little tentacles, they're like side to side, connecting each cell. They're like tiny threads. You see those on the illustration, on the x-ray. And what binds it on the outside are layers of similar bone, but not identical, cortical bone. If it's circumferential, surrounds it. If it's interstitial, it's between. So again, there's like the glue and the binding that hold these multiple pillars to work. And that the body does what I mean, so you can have, it's the beauty of being able to biologically create something we can mirror in life. Rather than having just two supports on something, I'm thinking biblical Samson, temple, the whole thing, Delilah. Okay, as opposed to having multiple pillars. He couldn't have brought that temple down, the Philistines. Biblical history, Biol, What? I'm thinking about telling you about the movie from 1948, but I think you'd laugh at me. The lady who starred in that movie, named Hedy Lamarr, escaped from Nazi Germany. Was a star, beautiful actress. Did one of the earliest nude scenes in film. And people didn't like the way they photographed it. Later, she helped to design. She was an inventor when she left acting. Actress. There's a wonderful biography of her, and I think she created sonar. Her idea of certain kinds of radio and sound waves eventually became sonar for the military. It's a pretty smart cookie. She played Delilah in that movie. So osteon, structural unit, elongated cylinders, long axis, tiny weight-bearing pillars, layers, rings of bone. So what you're going to see, the tree trunks, the hollow in the middle, central canal, main blood supply. Every ring different. I'll show you why. But all of them contain collagen fibers, resist twisting and turning, and then the bone salts are deposited. This may be the best illustration in this whole textbook. There's a couple. This one. Look at the interior design of the human body. You have here's the central canal, the main blood supply, up and down of the osteoid. First layer of fibers went in one direction, either let's call this for argument's sake, counterclockwise, clockwise, counterclockwise, clockwise, and then it's all filled around the collagen fibers are those calcium binding with the calcium. Imagine the strength. The little bonds in between them. Every time that bone, how many times have you run around, put your ankle, twist it a little bit, and kind of wonder, why didn't it break? I really hurt that thing, but it feels okay. They're called sacrificial bonds. They'll give way rather than let the bond. It's a two-edged sword. So if anybody like people like me who did orthopedics, I did emergency orthopedics, who would much rather have a simple fracture than a bad sprain. It's a lot less to heal. Bones heal, and it's pretty reliable. Those sacrificial bonds will break to absorb the stress so the bone doesn't break, and it reform as soon as the stress goes away. Design. To me, it's fascinating. That's why I love the anatomy. I was talking to arguably the best student we had last year in nursing in AP1 this morning. And this is what she said to me. It's so important. The students are having trouble, and what she's taking now, which is pathophysiology, a very difficult course that starts the second year of the BSN program, are the ones who had trouble and didn't do well in the anatomy, or had trouble with it. Okay, are really having trouble with this. I'm not saying this to make you study. I'm trying to give you an idea. She was very objective with me about what was going on, because I'm curious, because I was very fond of all my classes. I was curious to see how some of these folks were doing. Thanks. Have a good rest of the day. Thanks for letting me know. So here's that canal running through it. Here's the perforating. It's the other name for them, are Volkmann's canals, going at right angles toward the center. Here are the lacunae, the little hair-like canals. You'll see the illustration. Gap junctions, the interstitial, the lamellae that glue them together, the circumferential ones that basically surround. You'll see the illustration. Here it is. Fibers going in different directions. Here, multiple pillars, counting just here, maybe 6 or 7. These are the interstitial lamellae. These are the circumferential ones that basically, and now exterior, you begin to see cartilage, or depending on where it is, periosteum, blood vessels, perforating fibers we talked about. Here it is a real micrograph. You can see the blood vessels. The little dot-like areas, little ovals, those are the lacunae. Okay, you really can't see what's in them. But the fact doesn't mean there's not anything in them. It just looks that way because of the staining. Same thing here. So, I mean, here's that central canal. Here you can begin to make out the layers. These little hair-like threads going away this way and side to side this way. You can see them here and here and here and here. They are, by definition, the little canals are canaliculi. They're all about those tentacle-like projections that are there. So, and now we get the spongy bone. It's interesting. It's a great analogy. It's like a suspension bridge. And all those cables on it give it strength. That really helps, sort of like spreading the weight. When you see like a giant bridge like the Verrazano Narrows or the George Washington, we don't have one, Golden Gate. I mean, you got those two giant things, and then you have those giant suspension lines. And imagine all the weight of all those vehicles at any one time. It's unbelievable. I mean, most of Verrazano and the George, I'm sure probably the Golden Gate, they have 2 levels, if you didn't know that. You know, with like 6 lanes each way. You got 12 lanes here, 12 lanes there. Some going in town, some going out of town. Charging $15. Probably 20. How times have changed. I think it was about $2. My buddy and I would leave school. He picked me up after his work. He picked me up for my last class. We'd drive into Chinatown in Mott Street in New York City for like a midnight snack on paying $1.80 for $1.60 for a big bowl of lo mein. And tea served in a drinking glass. None of that, Asian cuisine with the neat little circular bowls. That's how the folks live there. Again, somebody else going to give me a hard time. 4 years ago. We were like you, different. People never change. The generations change. You say, so all of that, they don't have the osteons, but the trabeculi, they're arranged to really buffer stress. Again, same illustration you saw before. Almost done for this section. Organic, the osteoid, mineral salts, mostly calcium phosphate by far. And this is the proportionality. Half as strong as steel pushed on, as strong as steel bent or twisted. Bone. Your bone. The osteoid is all the organic material, ground substance, collagen fibers. Here's the sacrificial bonds. Very important word, hydroxyapatite. How you pronounce it, I'll write it out. They're the calcium salts, mostly calcium phosphate by far. 2/3 of the mass of the bone. That bone gets its weight from the calcium salts. Hardness and resistance, that's why they stick around after we die. We're done there. We'll start the next unit after the break. It is whatever it is, 4:06, quarter after, 9, 10 minutes when my voice recovers.